suffering from fever that is indicated clinically by the increased pulse rate. When the pulse rate is increased, it means either the person is nervous or the person is having fever. So whenever there is a rapid heartbeat, means 72 beats per minute, this is a normal one. But if somebody has got 10 beats more, it's in 1 degree is usually raised, 1 degree temperature. Okay, he is giving a history that he had acute appendicitis, and then now he had pain that suddenly increased. Now in the history, he was saying that he had acute appendicitis previously, but definitely it was treated or something like that. But suddenly again at the same spot, he's feeling a pain, and that is a sudden increase in the pain. So pain was there, appendix was there, it was inflamed, it might be treated, but it was not removed out, excised. So now he is getting a sudden rise in the pain, and on the examination, this is in medical terms, it's called physical examination. Physical examination means the doctor is touching the patient and trying to examine the complaining part. So if just like if you go to the doctor for sore throat, the doctor opens your mouth and try to look into the posterior pharyngeal wall. So by putting the torch and the tongue depressor, that depresses the tongue, and he want to see the tonsils and the oropharynx. So that he come to know what is the severity of the sore throat. So this is that you are examining the patient at the site of the complaint. This is called physical examination. So here the site of pain is the lower abdominal quadrant. So he will examine that area, and there are different examination for different complaints. So here, since it is anatomical case, it is surgical case, so it may need surgery. So the surgeons will do some examination on that side, and those examinations, they are called as the SOS sign and this and that, what is uploaded in the video. So on examination, the muscle of the lower part of the abdominal wall in the right lower quadrant showed rigidity. Rigidity means tightness, something becomes stiff. Your abdomen in the normal condition, if you are laying down, your abdomen is very soft. But if in different conditions of the abdominal problems, that softness is gone. And usually in constipation also, sometimes you may find the stomach as a rigid part. It is not that much soft. So in any disease that involves the inside of the abdomen, it may cause rigidity. Rigidity is an involuntary action or contraction of the abdominal muscles. So when the abdominal muscle becomes more contracted, it will make a hard abdomen. So that become very rigid, tough to bend, right? So when the doctor want to examine the abdomen of this patient, the abdomen of this patient is very rigid. Why? Because of this involuntary abdominal muscle contraction that is called rigidity, right? And why it is happening, we will when we proceed further, then we will know what is the problem and what the problem is causing the rigidity. Here, just for a glimpse, there is a peritonitis, inflammation of peritoneum after perforation of the appendix. Perforation means an opening, means so appendix, it is opened up, means it is ruptured. So it is ruptured due to chronic infection, chronic inflammation, right? So previously the appendix was not excised, means it was not removed, and the disease keep on lingering into the body. So recurrent infection causes the abdomen to be very swollen, and the wall become very weak. So when the pus inside the appendix, it applies pressure on the wall was weak and it bursted out. So all the pus from inside of the appendix is now outside the appendix inside the peritoneal cavity. So when it goes to the peritoneal cavity, those an infection, they touches the peritoneal membrane. Peritoneal membrane is nothing except the squamous membrane, right? Squamous epithelium. There is a mesothelium origin. So those peritoneum, they got infected. So when the peritoneum of one area is infected, this peritoneum, since it is a continuous sheath that is covering the whole abdomen, the wall of the abdomen and the visceral surfaces, so it becomes a very serious emergency condition, because the peritoneum is a life-threatening situation when it is a peritonitis. So this rigidity is one of the sign of peritonitis, and peritonitis occurs when any infection comes out to infect the peritoneum. So here the appendix is ruptured and it goes out to the peritoneum. Now in this slide, these are some of the objectives that you will study in this case. What the McBurney's point, you will find the blood supply, abdominal wall, okay, positions of the appendix, soft signs. So there are signs, there are some basic information in slide in this case, and then we'll go to the clinical side. So this is a very basic anatomy of the anterolateral abdominal wall. You know, anterolateral means anterior and lateral abdominal wall. So when a surgeon want to do a surgery, he must know the layers of the abdominal wall. So anterolateral abdominal wall from the skin up to the parietal peritoneum, right? So all the structures, they have to be incised, cut down to go inside the abdomen. So these are the step by step in sequence, the layers of the abdominal wall from skin, superficial fascia, deep fascia, muscles, fascia transversalis. Fascia. What is this fascia transversalis? Fascia transversalis is actually epimysium of the transversus abdominis muscle. So transversus abdominis muscle, the innermost muscle, and every muscle is covered up by some fascial covering. So you know about the epimysium, perimysium, endomysium, right? So the epimysium of the transversus abdominis muscle, that is called as the fascia transversalis, right? Then extraperitoneal fascia and parietal peritoneum. So parietal peritoneum is attached with the fascia transversalis by means of this loose connective tissue that is called extraperitoneal fascia, right? This is similar to endothoracic fascia that is present in the thorax that stick the parietal pleura with the wall of the chest, with the ribs. So endothoracic fascia in the thorax region, and here in the abdomen, what glue we are using, it is the extraperitoneal fascia. So that stick the parietal peritoneum with the fascia of the transversus abdominis muscle. Now umbilicus is a scar presenting the site of attachment of the umbilical cord in the fetus. Yes, what is umbilicus? You know, in the fetal life, vitelline ducts and arteries, veins, umbilical arteries, veins, they go inside and outside, and they are connected with the digestive system. So there's the spot where those vessels were going in and out. It is situated in the linea alba. What is linea? Linea means straight and al means white. Albinism, if you heard about a disease, albinism, the whiteness, the disease of whiteness, when the uh, melanocytes they fail to produce melanin and the skin become white and the hair become white, everything. Albinism. So alba, white, linea means straight. What is here? Where is linea alba? This straight line is called linea alba. This linea alba is important because this is the connective tissue that is actually the union point of the two-sided muscles. So on the right side, we have anterolateral abdominal muscles like external oblique, internal oblique, transversus abdominis, and the anterior side we have got the rectus abdominis. All these of one side, they are joined with the left side by means of this common fascia, right? So this is the linea alba where the two fascia of the two-sided muscles, right? Right part of the rectus abdominis and all the muscles, and left part of the rectus abdominis, all. So they are all joined and zipped together. This is a zipping, you can say. The abdominal wall is zipped here because half is coming from the right side, half is coming from the left side, and both of them they joined by this linea alba. So this is the fascia, connective tissue that joins the two half of the anterolateral abdominal wall. Okay, the skin is loosely attached to the underlying structures except at the umbilicus. Okay, the skin with the superficial fascia, deep fascia, they are attached with the underlying structures, right? The fascia of the muscles, except the umbilicus. So except the umbilicus means loosely attached everywhere. The skin is loosely attached, but at the point of the umbilicus, the skin is tightly attached with the underlying structures, right? So umbilicus is tightly attached. If you feel yourself, if you want to move the umbilicus, it's very hard, right? But you can move the skin everywhere very easily because it is very slippery. But at the point of the skin, at the point of the umbilicus, they are fixed with the underlying structures. Any question from this slide? You are free to type the message. Okay. Now come to the anterolateral abdominal wall again. Now come to the fascia, superficial fascia and the deep fascia. Previously, if we recall, in the skin, we have studied the skin is composed of epidermis and dermis. These are the two primary layers of the skin. Hypodermis, some books include as a third layer. Most of the books, they don't include this hypodermis as one of the part of the skin. But this hypodermis is actually the superficial fascia, right? So below the skin, you will find the superficial fascia, the hypodermis. And hypodermis in the abdomen, only in the abdominal region, it has a distinct feature. Distinct feature means a very characteristic feature that this superficial fascia that is usually composed of the fats, they are divided into two layers, the fatty layer and the condensed fatty layer. The fatty layer above one, this is superficial fatty layer. Since it was discovered by Campers, so that above fatty layer is called Camper's fascia. And the lower condensed fatty layer, condensed means compressed, right? So it is a dense connective tissue, dense layer of the fatty tissues. So that is the deep membranous layer. And this was discovered by the Scarpa, so it is called Scarpa's fascia. So this is a particular feature of the superficial fascia only usually present in the abdominal region, right? You may not find even, okay, will not go to its demarcation from where to where. Just remember the skin of the abdomen, the superficial fascia of the skin of the abdomen consists of further two divisions, Camper's fascia, a pure fatty layer, and the Scarpa's fascia, which is a this Scarpa's fascia is thin and fades out laterally and above. So this deep fascia is not actually completing the whole of the abdomen, 100% of the abdomen. No, as you go away from the central point, the anterior part, so it fades out laterally and above, right? So mostly it is present in the very front surrounding the umbilical area, right? So 1 foot, if you do, I think around 1 foot diameter around the umbilicus, you will find the Scarpa's fascia as the prominent feature. Then later on, if you go further on the very lateral or very posterior, you will not find the Scarpa's fascia. You will only find the superficial, the Camper's fascia. Then below the superficial fascia, again we have the deep fascia. Okay, before going here, I saw here superficial fascia or the rest of the body may extremely thick in obese patient. In obese patient means adults of our age, so you can find that sometimes there are big bellies coming out. So that big belly of fatty fats, so that fat deposition is actually depositing in which, in the superficial fascia, Camper's fascia. So Camper's fascia is itself a fatty layer, so all the fat deposition goes to Camper's fascia, not to the Scarpa's fascia, which is membranous. So always remember this thing. Now come to the deep fascia, like due to the membranous layer of the superficial fascia and this thin layer of connective tissue covering the muscles. So the purpose of the deep fascia is a deep connective tissue layer, right? And it covers the muscles. So any question from this slide? Next. Can you all hear me, what I am doing and what I'm describing? Can anybody just type a message? Okay, thank you very much. Thanks a lot. Okay. Now come to the muscles of the anterolateral abdominal wall. 5 muscles make up the anterior abdominal wall, 3 flat muscles, 2 vertical muscles. 3 flat muscles, I think we have discussed a lot: external oblique, internal oblique, transversus of abdominal. So these 3 muscles, they are oblique muscles and transversus is horizontal. So they are flat muscles, right? They are considered as flat, means the shape, the membranous sheath like coming from the posterior side and then going to the lateral and come to the anterior and join together in the linea alba. So there is the linea alba in the center, and here you will find all these two-sided muscles. They will join together. Okay, 2 vertical muscles. Okay, what's the direction of the muscle gives tensile strength? Tensile strength means to bear the tension, means what you are moving in that direction of action, it will provide you the power. Okay, 2 vertical muscles, rectus abdominis, pyramidalis. Rectus means straight, so this is the rectus abdominis muscle, right? Pyramidalis is here, a very small muscle, pyramidal in shape. So from the pubic tubercle pubic line, right? So here the pyramidalis muscle, not shown here. Okay, they are located in the midline. These are enclosed in the tendinous sheath of rectus sheath. Rectus abdominis. The sheath that is just below, that finishes below the umbilicus. So that sheath is called the rectus sheath. So if you, this is a rectus muscle, posterior to the rectus muscle up to the level of umbilicus, there is a fibrous sheath at the back of the rectus abdominis, right? So that sheath is called rectus sheath. So there are some arterial anastomosis there. Weakening defects, trauma, and these muscles causes bulging and result in hernia. So these 2 muscles, rectus abdominis and the pyramidalis particularly, but it also include the these muscles also, the flat muscles, particularly this external oblique muscle. So this, if they are weak, so they may cause hernia. Hernia in the medical terminology, protrusion of the contents from the cavity to outside. So abdominal content may come outside if these fibrous tendinous sheaths, they are weak. So it's a big discussion. Any question from this slide? Where's the rectus sheath? Somebody is asked. So you cannot find rectus sheath anteriorly. It is only present on the posterior surface of the rectus muscle, right? So up to the umbilicus, it is not only 100% covering the posterior surface, right? So from xiphoid to the umbilicus on the posterior side. It is the blood supply. Blood supply, I think we have done so many times. So midgut, I told you earlier what is the extension of the midgut. Midgut starts from the point where the divides the digestive system into 2 parts. Above the penetrance, this major duodenal papilla, this bile duct and pancreatic duct, the opening, Above that is all foregut, and below that point is all midgut, right? So midgut starts below this penetrance of the main pancreatic duct and the common bile duct. So their blood supply, foregut means above this point, above this penetrance at the second part of the duodenum. So the first part of the duodenum and half part of the second part, that is called as is included in the foregut. So this half of the first part of duodenum, then stomach, esophagus. So this is the foregut, and below this half of the distal half of the second part of duodenum, third part, fourth part of duodenum, then jejunum, ileum, cecum, and this ascending colon, transverse colon, the proximal two-third of the transverse colon. The junction between the proximal two-third and the distal one-third of the transverse colon, right? Here you may find the transverse colon cut down here, right? So this, okay, come to this. So this is the junction here, transverse colon. If you divide this transverse colon into three parts, the junction between the proximal two-third, this proximal two-third, because this is the origin of the more towards the origin, and this is the one-third. So here somewhere, this is the point. So this is the point that is called the point between the midgut and the hindgut. So midgut ends at the junction between the proximal two-third of the transverse colon and the distal one-third of the transverse colon. At this junction, everything is imaginary, right? So there is no anatomical spot that you can say this point here particularly. So this is a rough idea that all the blood vessels that is supplying the midgut will end up here, and the distal one-third of the transverse colon, and then the descending colon, and the rectum, sigmoid, rectum. So they are all supplied by the inferior mesenteric. So coming to this middle part, the midgut. So midgut starts from the second part of the duodenum to the two-third of the transverse colon, proximal two-third. Here we should write proximal two-third of the transverse colon. This is supplied by superior mesenteric artery. Superior mesenteric artery arises from the front of the abdominal aorta, just below the celiac artery. So if you enlarge this figure, this is the celiac trunk. Some of the branches going to the liver, some are going to the spleen, splenic artery, common hepatic artery, and some left gastric artery. These are the branches of celiac trunk. And below that one, here, just behind this pyloric part of the stomach, you'll find this big artery. This is the superior mesenteric artery. So superior mesenteric artery is actually the artery supplying the midgut, and you should know what is the extent of the midgut. Extent of the midgut means from where it starts and where it ends. Okay, so you know now what is the extent. Extent is starting from the point of entrance in the second part of the duodenum, the common bile duct and pancreatic duct, up to the junction point between proximal two-third and distal one-third of the transverse colon. Now, superior mesenteric artery supply distal part of the duodenum, jejunum, ileum, cecum, appendix, ascending colon, most of the transverse colon. So most of the transverse colon means the proximal two-third of the transverse colon. Any question from this slide? This is the venous drainage. This is also discussed in the digestive system. Venous blood, greater part of the digestive GIT and its accessory organ drained to the liver by the portal vein. So if you see the digestive system, only the upper two-thirds of the esophagus and the lower one-third of the anal canal or the rectum, right? So that area is exception, because those area, the venous drainage is through the systemic veins, right? It's like here in the slide, if you follow this thing, upper 2/3 of the esophagus drains into the azygous vein. Azygous vein, these are the intercostal veins of the thorax, right? So azygous vein on the right side is azygous, on the left side hemiazygous, accessory hemiazygous. These are the merger of the intercostal veins of the thoracic region, right? They merge, they form the azygous, and ultimately drain in the azygous, the posterior surface of the superior vena cava. Azygous vein drain into the posterior surface of the superior vena cava. So whenever you see the superior vena cava in the heart model, if you find on the posterior side an opening, so that opening will be the opening of the azygous vein. So this is the part of the systemic circulation, right? So upper 2/3 of the esophagus drained by the systemic venous drainage, right? When we say systemic, means we are talking here about the veins, venous drainage. Here again, systemic venous drain, the inferior rectal veins. Inferior rectal vein, so lower half of the anal canal is drained by the middle and inferior rectal veins. So rectum, if you see here, there's the upper part of the rectum and the lower part of the rectum that is drained by the systemic veins. So systemic venous drainage, they are the part of the pudendal veins going to the internal pudendal vein and internal iliac vein and inferior vena cava. So these two parts, they are drained by the systemic venous blood, right? And then come to the portal vein. So portal vein is also vein. Systemic venous drainage is again a vein, right? So wherever these points, they are called portosystemic anastomosis. So one point is here and the other point is here at the esophagus, right? So lower 1/3 of the esophagus and the upper part of the rectum and the anal canal, they are all drained by the upper part of the rectum, they are drained by the portal vein, right? Rectum and anus is a continuous structure, right? Rectum and anus, they are venously drained by superior rectal, middle rectal, and inferior rectal, right? The superior rectal is the branch of the inferior mesenteric, right? Which is the part of the portal vein. So upper half of the rectum will be drained through the portal venous blood, right? While the lower part of the rectum and the anal canal, they will be drained by the systemic veins that are the middle and inferior rectal veins. So middle and inferior rectal veins, these are the tributaries of the internal pudendal vein or the internal iliac vein that will go to the inferior vena cava. So it's a part of the systemic circulation. So that's why here an anastomosis develop between the systemic inferior rectal, middle rectal, and the portal superior rectal. So anastomosis means these veins become intermingle with one another, become continuous, and they form an anastomosis. Similarly, here in the esophagus again, the upper 2/3 that will drain into the azygous vein, and the lower 1/3 that will drain into the left gastric vein, right? This is left gastric vein, and left gastric vein is giving this small branch that is called as the lower 1/3 esophageal tributary, right? So gastric vein gives a branch, right? Gastric vein is somewhere here, right? So here is the esophageal tributary of the left gastric vein, right? So this tributary will drain the venous blood from the lower 1/3 to the portal system, right? The blood will drain from the lower 1/3 into the portal system, right? While the upper 2/3 of the esophagus, that will be drained by the azygous vein. So that will be drained by the azygous vein. So here at the point and the lower 1/3, at that point, there is an anastomosis between the venous tributaries that are coming from the azygous and the portal, right? So they anastomose here same as here. So these two are very hot spot in diseases that causes block in the liver that stop the drainage. Because in the disease, just like in hepatitis B and C, it makes the liver to solidify. So all the veins, they are compressed, they are blocked. So all the veins that were draining to the heart indirectly through the liver, here the back pressure will increase, right? And that back pressure will develop a bulging of the veins in the anal canal in the form of hemorrhoids. And here again, the back pressure will increase the venous blood at the junction, upper two-third, lower one-third, at that junction, and also the back pressure will bulge out the veins in the esophagus. And they are, both of them, they are easy by the scratch of the food here in the esophagus, by the fecal material here. So after defecation, bleeding occurs here, and after swallowing any food, bleeding can occur here, and the blood will come here in the stomach, and hematemesis will occur. So portal vein drains blood from the most of the GIT, from the lower third of the esophagus, lower one-third of the esophagus, to halfway down to the anal canal. So it drains the spleen, pancreas, gallbladder. The portal vein enters the liver and breaks up into sinusoids, from which blood passes into the hepatic veins that join the inferior. Any question from this slide? Now this is what this is again an anatomy. I sometimes describe more just to make the things clear. It will help you in future, inshallah. Now, what is this? In concept building is very, very important at this stage. What you are doing, why you are doing. Now, main arteries, why you are studying arteries here. Can you see this hip bone and the anterior superior iliac spine, and you can see this inguinal ligament that is going to attach here at the pubic tubercle. This is the inguinal ligament, and that is very, very important. This is the Mexican border, means this is the border. Above this one is abdomen, and below this ligament is our lower limb. And this is the common iliac, this is the internal iliac, external iliac. As it crosses the inguinal ligament, it becomes femoral artery. So internal iliac artery, or external iliac artery, crossing the inguinal ligament becomes femoral artery. Now, why we are studying here? Because there are two arteries running along with the inguinal, and this is the side iliacus, right inguinal fossa here, where the appendix and everything is there. So if you want to make an incision on the skin, so you must know what arteries are below the skin and they are running, so they are in danger. So these two parallel arteries, one above and the other one lower the inguinal ligament. So one is called superficial, the other one is called deep. So this one, the lower one is superficial, the other one is called deep. But both of them, they are running along with the inguinal ligament. The superficial one is a branch of femoral artery, and the deep one is a branch of external iliac artery. This is the internal, this is the external, will go out of the pelvis, internal will go inside the pelvis. Now there are other two on the medial side here. If there's somebody has made a long incision up to the medial side, so they may cut these two arteries. These two arteries, they are deep epigastric artery and superficial epigastric artery. These epigastric arteries, they will go vertically upward and join with the deep and superficial epigastric arteries, the branches coming from the musculophrenic arteries. Okay. Now these two arteries, they are running on the medial side. So if the incision is made perpendicular like this, it will cut these arteries. If the incision is long and going to the medial side, it will cut these arteries, right? These are the superficial and deep. Now here again, the superficial one, they are the branches of the femoral, and the deep one, these are the branches of the external iliac. So deep circumflex and deep epigastric, both of them, they are branches of external iliac, while the superficial circumflex and the superficial epigastric, These two are the branches of the femoral artery. So long inguinal ligament runs superficial and deep circumflex artery, which is a branch of femoral and external iliac artery respectively. Other arteries are superficial and deep gastric arteries, which run straight upward in the anterior of the abdomen, which are branches of femoral and external iliac artery. Any question from this? Now, this is the picture showing appendicitis symptoms. So what are the symptoms? They are usually some fever, 38 degrees centigrade. These are initial condition, right? Not in this case. These are general ischemic picture. Some might have abdominal uh, pain and have vomiting. This is the pinpoint site for the appendix, and you know why it is, because the appendix is located here. Then we got painful urination. So urine becomes more painful because of infection, belch, because the gas will come out, because the gas filled sometimes in very severe condition. The stomach, the intestine is blocked and nothing can go forward, so things will go out. So gases will come out from them. Then the constipation or diarrhea is also the signs of. So every sign here you'll find related with the GIT, except this general fever. So any question from this slide? Come to the next slide. Now here comes the clinical side. Acute appendicitis signs. What are the signs? Sign and symptoms. We have heard so many times. Symptoms, the patient, what it tells about, and the sign is what the doctor look at. So here the patient came with severe pain and all these things, right? Vomiting, and it was a history of appendicitis also. So acute appendicitis, acute means very sharp inflammation of the appendix. So what are the signs? What the doctors will see? Looking pain, low grade fever. The fever, when he check the fever will be low grade there. This is for the general purpose, not in this case especially, because this case is perforated appendicitis. Coughing may cause increased pain. So when a patient is also coughing due to any respiratory problem, that will also aggravate the pain at the right lower quadrant. So that is called Dunphy's sign. Dunphy was the scientist. All these names, Roving, McBurney's, so these are the scientists, so they put their names. So they're nothing special. So Dunphy says, okay, I saw that when appendix patient, it has suffering from cough also. So the pain aggravates, and that sign is called Dunphy sign. Okay. Tenderness at McBurney's point, involuntary guarding. Involuntary guarding is actually the rigidity. Guarding means protecting. So when the appendix is inflamed and very sensitive to pain, the abdominal wall becomes very rigid on the upper side to form a shield. So nothing could touch the appendix. So that involuntary action of the stiffness of the muscle, that is called rigidity. So that guarding, involuntary guarding, is rigidity. Otherwise, guarding is sometimes supposed to be voluntarily. So voluntarily, you also guard your abdomen while boxing. If somebody is hitting on the abdomen, you tighten up your muscle voluntarily. That is just a guarding, right? That is not rigidity. Rigidity is a clinical disease, pathological condition, and it is involuntary. Whether you want it or not, rigidity will occur. Site of tenderness may vary depending on the position of the appendix. Position of the appendix is again very important. Pain felt in the right lower quadrant during palpation of the left lower quadrant. Roving sign. I have uploaded some videos, and before joining the CBL session, if you might have studied the note that is below those videos, they are very important, right? So video is just for understanding, but the note that is written below those videos in the blackboard, that is very clear, and that explains some of the slides in the CBL. So roving sign, again we will discuss perforated appendicitis, more severe and diffuse abdominal pain, tenderness, abdominal wall rigidity. So perforated appendicitis, inflammation of the appendix, that is perforated means rupture. So things get out of the appendix and has created peritonitis and causes rigidity. Next, any question? Okay, now this is the anatomical positions of the appendix, and that makes the difference. So what sign we are uploading in the blackboard, and what, this is all because of this positioning of the appendix. Because if you know the position, it's easy to do surgery, because this appendix is a suspending. Can you see this 1, 2, 3, 4, 5, 6 positions? Only the mouth of the appendix, the base of the appendix is attached with the cecum, right? So there is a cecum, ascending colon, and how you can find determine the mouth, the attachment of the appendix. Just trace these tinea coli. These three tinea coli, when they join at the very bottom, there you will find the mouth of the appendix, right? And the tail of the appendix is not fixed, so that's why the tail moves all around in different angles, in different position, and that becomes very problematic while doing the surgery. So you need to know where to incise, because you cannot cut all along the line just from here to here. No, uh, everybody wants to be safe. So you need to know first where lies the appendix. So these are the position. Can you see this dotted line? This dotted line showing that this appendix, that the tail of the appendix, it is behind the cecum. So that's why it's called retrocecal. The retrocecal position of the appendix, when the appendix is behind the cecum. Paracecal, beside the cecum. Subcecal, below the cecum. Pelvic, in the pelvis, because here the pelvic area, this is what promontoric. Promontory is there. That's promontory is the uh, what you say, the first sacral vertebra has got upper superior margin that is very protruding. That is called as the promontory of the sacrum. So, okay, this one is called subileal also. Subileal, below the ileum, this is the ileum, ileocecal junction. This is post-ileal, pre-ileal, right? So before ileum, after the ileum. So these are different positions. So you need to know, so you need to remember these two positions, retrocecal and paracecal, right? This is on the lateral side, right? This is very important in the SOS sign, iliopsoas signs, because lateral to the cecum, which muscle is here on the lateral side, you'll find there's the iliopsoas muscle there, right? So that's why you need to do something with that muscle. On the medial side, if you come here, pelvis, when it goes to the pelvis, there is a muscle here that is called the obturator muscle. So obturator muscle is the muscle that forms the lateral wall of the pelvis. So if the appendix is placed in the pelvis, and if you do something with the muscle, stretch the muscle, that uh, muscle will show more pain in that action, right? So it means that the appendix is lying in the pelvis. If the iliopsoas muscle, when you are stretching the iliopsoas muscle, and if the appendix is there in the paracecal or retrocecal position, so they are lying on the muscle, psoas major or iliacus. So when you do stretching of the psoas major or the iliacus muscle, these two will indicate that the appendix is placing either on the iliacus or psoas, means paracecal or retrocecal. So retrocecal, paracecal, psoas muscle, right? Iliopsoas muscle. Pelvis, obturator muscle, right? Then these two, they are not related with muscular stretching, but they are related more with the ileal, means digestive symptoms, vomiting, constipation, uh, block. So we come to the next slide. So this positioning is important related to the muscles. Now come to the McBurney's point. Okay, we will go slide by slide because things will come, and just understand the slides first. McBurney's point is the point where usually the mouth of the appendix, not the tail of the appendix, mouth of the appendix is attached with a cecum. So this is the point. How you will divide it? From the, what is this point of the hip bone? This is called the anterior superior iliac spine. And what is this? This is the umbilicus. Draw an imaginary line, divide into three segments, 1, 2, and 3. The junction between the lateral 1/3 and the medial 2/3, that junction here, this is the point where the base or the mouth of the appendix is usually placed. But then not the tail. We are not talking about the tail because tail is very versatile, means cannot be, but this is a fixed point. So in oral surgery, when you need to incise the abdomen and by cutting the abdomen, so you need to cut over here. So at least you will get at the base of the appendix, so you can get the tail. So anterior superior iliac spine. The posterior rough corresponds to the most common location, the base of the appendix. Okay. Roving signs. Roving was scientist. He discovered one thing, that if you press on the right side, on the left side, here, this is the abdomen, appendix is here on the left side, left lower quadrant, left inguinal fossa. But if you press deeply on the left inguinal fossa, then you will find the pressure that will go from the right side due to this compression. It will press the appendix here, and the patient will feel pain in this side, at the side of appendix. So you are pressing the right, you are pressing the left inguinal fossa, but the patient will feel pain on the right inguinal fossa. So left pressing, pain comes on the right side. This is the sign discovered by Roving. So who was born in this. So this is the Roving sign. The video is also already uploaded. Now McBurney's point, typical presentation, Roving sign. So McBurney's point for what? For the identification of the mouth of the appendix, and it is in the left, right lower quadrant or left, right iliac fossa. Typical presentation of Roving sign. So here at this point where you are in the McBurney's point, the lateral 1/3 and the proximal 2/3, the junction, the line, imaginary line that is between anterior superior iliac spine and umbilicus, the medial 2/3 and the lateral 1/3. At that junction point, if you press, the patient will feel pain in the appendix. So this has become a sign, a positive sign that okay, there is something wrong at the base of the appendix. So this is called typical presentation, McBurney's point. So sometimes this McBurney's point, also called as McBurney's sign. So point is that, and sign become positive. When you press at that point, you will find pain. So McBurney's sign will become positive. Now Roving sign. What is the Roving sign? When you are pressing on the left side, left inguinal fossa, and the pain is coming on the right inguinal fossa. So that is called, that is typical presentation. Typical presentation, Roving sign. So the pain will feel at the McBurney's point. So you are pressing on the left side, left inguinal fossa, but the pain will be felt at the McBurney's point, right? So this is a very typical presentation of the appendix. So this is the roving sign. So roving sign become positive if there is a pain that occurs on the McBurney's point while pressing the left inguinal fossa. The pain will aggravate on the McBurney's point. Retrocecal, paracecal, retrocecal behind the cecum or paracecal beside them. So what is SOS sign? Flank pain, absence of peritonism. SOS sign, SOS major and iliacus, iliopsoas. This is the muscle, the merger of the two muscle, iliacus and the SOS major. But sometimes it is called only SOS sign. SOS, the muscle name. So SOS sign is positive. Why? Because I told you here that the muscle that is on this side, these appendix, if they are behind the cecum or at the side of the cecum, they are lying on the muscle. So that muscle is the SOS major muscle or iliacus muscle. And if you move those muscles, disturb the muscle will disturb these appendix and the pain will increase. So this will indicate that the cecum is tail, the position of the tail of the cecum is on the iliacus or the SOS muscle. So this indicates, so this is called the SOS sign is positive. So SOS sign is what? When you do the SOS test, if in that test the pain aggravates, it means the position of the appendix is on the SOS muscle. Retro or parailial. Again, retro or parailial. Parailial means post-ilial, pre-ilial. Now here at the back or here. For this particularly, parailial, I told you, the most of signs symptoms, they are digestive. Diarrhea, crampy pains, very severe crampy pains there, right? So in that position, if the appendix tail is here, so that SOS sign will be negative. And here only the diarrhea and crampy pain will go. Pelvis, pelvic position for the pelvis, suprapubic pain, urinary frequency, pyuria. So these are the symptoms when the appendix tail is in the pelvic region, right? And also there is a muscle, obturator muscle, that will cause obturator sign. So if you disturb the muscle, stretch the muscle, the pain will aggravate. So this will indicate that in the obturator sign is positive. It's mean the tail of the appendix is positioned in the pelvic region. Any question? No. Retro means behind and para means beside. Retrocecal and paracecal, beside the cecum, right? Beside the cecum, here it is also beside and here they are also beside, right? But since here, just to differentiate between this and that, they take this paracecal as that is on the lateral side. And when coming on the medial side, they call them as sometimes parailial. So beside the ilium, so post-ilial and pre-ilial, they are also sometimes called as para-ilial. So para-ilial towards the ilium, beside the ilium, whether behind the ilium or in front of the ilium, pre or post. Uh, so it does not make any difference, right? Now, obturator sign. So we have discussed so many times what is obturator sign, obturator sign. What was the obturator sign? Obturator muscle. Obturator muscle, there's a video also in the uploaded one. Obturator muscle is this muscle. Can you see this muscle very small here? This is the pubis, ischium, obturator foramen. Obturator foramen of the hip bone is covered by obturator muscle. The muscle is attached to the margin of the obturator foramen. It covers, completely closes this opening, and that's why it is called obturator muscle. So this is the one attachment of the muscle. The second attachment of the muscle is going here, and this is the greater trochanter of the femur. So this is the lower attachment or distal attachment of the muscle. Proximal attachment of the muscle around the margin of the obturator foramen completely closes the obturator foramen, and then the distal attachment is to the greater trochanter, sorry. So greater trochanter of the femur. After crossing the head and neck, the greater trochanter is there. So this is the muscle called obturator muscle. And if the position of the appendix is pelvic position, the appendix is present in the pelvis. So this is the appendix here lying on the obturator. So if you do stretching of the obturator muscle by medially rotating the femur medially rotate. How you medially rotate the femur? 90-degree flex at the hip and 90-degree flex at the knee. In this position, turn your leg outside and press the knee towards inside. So it will rotate the femur. So medial rotation of the femur and lateral rotation of the femur. So actually the purpose of this muscle is to laterally rotate, but the doctor, to look at the stretching of the muscle, it will medial rotate this obturator muscle, medially rotated. So in medial rotation, what happens? The muscle becomes stretched, and when the muscle is stretched, appendix, if it is positioned here on the obturator muscle, this will be disturbed and the pain will aggravate, right? So internal rotation of the hip means internal rotation of the femur causes pain, suggesting possibility of the inflamed appendix located in the pelvis. So what is this? This is the pelvic part of the femur, right? The obturator fossa, obturator foramen, obturator muscle. So obturator muscle form the lateral wall of the pelvis. So if the position of the appendix is in the pelvic, is a pelvic position in the pelvis, the muscle in the pelvis is obturator muscle, and you can check by stretching this muscle by internal rotation or medial rotation. Internal rotation, medial rotation is the same thing, but what you are rotating, you are actually not rotating the hip, you are rotating the femur, right? So rotation of the hip means your internal rotation, rotating the femur. Femur is in the axial position, it is medially rotated or internally rotated. So in this position, in the video also, you will see how you can medially rotate or internal rotate the femur at the hip joint. So internal rotation of the hip means internal or medial rotation of the femur at the hip joint that will cause pain, suggesting the possibility of inflamed appendix located in the pelvis. Similarly, in the next slide, we'll see another sign. Now, this is the sauce sign. Sauce signs, here it is written as iliopsoas sign. Ilio for iliacus, sauce for sauce major muscle. So it's a combination of two muscles, right? If you go to the picture of iliopsoas in the Google, you will find iliacus, that is coming from the inner surface of the ilium of the hip bone, and the muscle, sauce major muscle, that is coming from upper side, upper 5 lumbar vertebra lateral wall. It is the upper attachment, and this muscle fiber of sauce major goes down and it combines with the iliacus muscle coming from the hip, ilium of the hip. Both of them, they insert by a common tendon to the lesser trochanter of the femur, not to the greater, lesser trochanter of the femur, that provide attachment to the iliopsoas muscle. So iliopsoas muscle is here. Now iliopsoas is on the lateral side, and if the appendix is retrocecal or paracecal, means on the lateral side, you will find the appendix is positioned on the muscle iliacus or the psoas major. So when you stretch those two muscles, right, by this action, iliopsoas sign, by stretching, by pressing the hand by the hand, push forward at the hip and just press this femur backward. So this action is called extension at the hip joint. So extension means moving backward of the femur. This will stretch the muscle that is on the anterior side, right, the iliopsoas. So that muscle will be stretched. So when this muscle will stretch, and if appendix is positioned in the paracecal or in the retrocecal, then that appendix will show pain. So the pain will aggravate in this action. So this is the positive sign that if there's a pain aggravates while extending the hip joint, this means the appendix is positioned either in the retrocecal or paracecal. So in different positions, you need to do some examination, some test. So those tests, they are called as the sign. So iliopsoas sign become positive when you are stretching the thigh backward. That is the action called as extension at the hip joint. So while pulling the femur backward, you are stretching the muscle, right? So the muscle is iliopsoas. When this is stretched, it will disturb the appendix and it will increase the pain. So iliopsoas become positive sign if there is a pain in this action. So extending the right hip causes pain along the posterolateral back and hip. So hip and the back side, you will feel pain, very much increase. So suggesting, yes, somebody is asked of that these tests we do just to check the position of the tail of the appendix, because base of the appendix is fixed at the McBurney's point, right? But the tail is very flexible in so many angles, so many directions. So the psoas muscle and the test, it will mention if the pain aggravates in this movement, it means the appendix tail is positioned in the retrocecal or paracecal. For the obturator sign, if it is positive while internal rotating the femur and the pain aggravates, so it is suggestive that, oh, the position of the tail of the appendix is in the pelvis, right? So these tests, they are usually just to find the tail of the position of the tail of the appendix, right? Next slide again, the psoas sign, pain on passive extension of the right thigh, same psoas sign, right? So this is the muscle iliacus, this is the psoas major, both of them common tendon attached to the lower trochanter. This is the appendix. If it is retrocecal or paracecal, it's not shown correctly here, right? It should be at the back side because it is not retrocecal, this appendix, right? But this test is positive only when the position of the tail of the appendix is retrocecal behind the cecum or paracecal somewhere here, right? Because this is the ilion part. So pain on passive extension of the right thigh. Patient lies on left side. So now this is the position, left lateral position of the patient, and then you are extending the hip joint, right? Pulling it backward. So examiner extends patient's right hip while applying counter resistance to the right hip asterisk. So at this point, you are pushing forward and you are pulling backward the thigh. So you are making extension at the hip joint, and that extension is stretching the muscle iliopsoas, right? So if appendix tail is positioned in the retrocecal or paracecal, then at this position the pain will aggravate and the patient will cry. So it's mean the appendix tail is positioned somewhere on the psoas major or iliacus muscle. Anatomic basis of the psoas sign: inflamed appendix is in the retrocecal position located in contact with the psoas muscle, which is stretched by this maneuver. Maneuver means by this doing this thing manually. Okay, this is the last slide, and they're just showing laparoscopic surgery. Lapar, what do we mean by medical terminology? Lapar means abdomen. Scopic, it's a condition of visualization of the abdomen. For appendicectomy, so your process of removal of the appendix. So how you can do this thing? You are using three. Here, this is the latest one that has been used for the past 10 years now, or 20 years, that they make three holes in the abdomen and put three rods inside. So first is just along the umbilicus. Second one is here on the left side. It is showing ending here, but take it here. So this is on the left side, and the other one is also on the midline below the umbilicus, somewhere here. So a typical placement of the access ports, these are called as the port. Portal means port means to carry something. So these are the instrument of carrying the things, right? Drawn at the umbilicus, left lower quadrant and lower midline. So at the umbilicus is this one, right? And left lower quadrant, this is the left side, lower quadrant somewhere here, right? So although it is showing the picture here, but the penetrance is here, the puncture is here. And the third one is a lower midline. So lower midline is this one. So below the umbilicus somewhere here. These are the three. They make a hole and then put these ports inside. One port for the camera, the other port for inserting the carbon dioxide inside the abdomen. A pneumoperitoneum. Pneumo means air, peritoneum cavity is created. Means one of the port, it inject actually the carbon dioxide inside the abdomen to inflate, to create some gaseous space inside so that you can see the structure and you can do your surgery. So this, out of these three, one port is for injecting or inflating the carbon dioxide inside. Okay, any question? Any question from this session? All clear. Alhamdulillah Rabbil Alameen. I tried my best to deliver the clinical things with some concept, and there are some uploaded videos are also there. So if you want to enjoy further and clear your concept, why it is happening, why this sign is taking place in this, these are all just to check the position of the tail of the appendix, right? While the mouth of the appendix is always fixed at the McBurney's point. So previously in old surgeries, we do at the McBurney's point and grab the appendix from the base. Wherever the tail it is, no problem. But if you get the base, you can pull out all the appendix. But in the latest technique is what? They only make three small drills, means openings on the abdomen. So the incision is not required, because for at the McBurney's point, the 4 inches incision is there, and that leads sometimes complication in cutting the arteries that we discuss, the superficial and deep circumflex and the superficial and deep epigastric arteries. So just to avoid the surgical complication and healing to be quick and less stay in the hospital, so they develop these new technique, laparoscopic surgery. So they insert these 3 tubes inside the abdomen, one with the camera, the other one apply the gas, and the surgery is done by the third one. So it is all through the camera monitor, computer monitor. You can see inside and you can manipulate your instrument. So these are the things. So it is a new technique. So now the McBurney's point and this thing, these are good for identification of the positive sign of the appendix. But for the surgery, now everybody is going for the laparoscopic surgery, and this is that. So for this, in conclusion, a patient came with emergency with a history of appendicitis, recurrent appendicitis, vomiting, all these things, and rigidity means inside the appendix was, since it was chronic, it ruptured, and peritonitis is there. So that peritonitis is causing the rigidity. So the patient come with this complaint. So you do your, you take the presenting complaint, history of the patient, and then physical examination. You do these tests: SOS test, Roving signs, or obturator test, or McBurney's point of McBurney sign. So these are very easy, but they are very understandable. So by that you can understand the position of the appendix, and then you can go for the surgery. Okay, any question? No? Thank you very much. And the session is concluded. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.